Hello, it's Caroline. So today the presentation that I'm going to give you is on clinical audit, which might sound a bit dry. I love a clinical audit. I'm a big fan of clinical audit and what it can do. So we're going to go through some different aspects of clinical audit and see what's happening from that point of view. And so from a learning outcome point of view, just want you to be aware of the evidence gathering techniques for clinical audit. Be aware of the differences between vertical and horizontal clinical audit. We'll go through some kind of different variations on audits and how we can carry them out. And at the moment, the vertical and the horizontal seem to be quite big, especially in audiology, I think, due to ICIPs. Understand the 5 steps of the audit cycle. Doesn't have to be a clinical audit, but of the audit cycle. Understand when it's a clinical audit, when it's research, when it's a service evaluation, and when it's best to carry out each one, and how we would go around carrying out each one. Obviously, we need to know about the confidentiality and the ethics related to any kind of clinical audit we carry out. And I've kind of, not a statistician, but we've went into a little bit just on the descriptive stats we can use with a clinical audit just to report and get our information across. So to geek out a little bit with a bit of history, the first clinical audit was thought to be carried out during the Crimean War by Florence Nightingale. She was appalled at the unsanitary conditions and high mortality rate of soldiers. I think this is in relation to she was taking care of soldiers, so she was nursing them. So in those conditions, it was unsanitary and there was a high mortality rate. I think in general, probably during the Crimean War, there was quite a high mortality rate for soldiers, so it was a bit of an occupational hazard. But this is in relation to the hospital where they were getting cared for. So she started to keep records of what was being cleaned, when it was being cleaned. I think everything in relation to that, and the mortality rates dropped. I think from about 40% to 2%. So yeah, massive change on kind of one of the most basic. Again, infection control will be on you, especially at the moment. Obviously a little bit increase with COVID and things like that, but it's just to show how much that infection control can change the mortality rate. Ernest Codman, again, clinical outcomes following surgery, and then it comes on that there's NICE guidelines produced, so everybody kind of has to follow these guidelines and do some clinical audits and check and monitor different aspects of everything from referrals to cleanliness. Everything has to be kind of monitored and audited so that we can get the best health outcomes and get recognisably high standards of care. It also leads to, transparent accountability. So we've got a duty of candour. We have to say when we've done wrong, and actually these audits or any clinical audits can be quite good. Everything is anonymised. It can pick up errors in the system. It can pick up errors where one person is maybe constantly doing it incorrectly. Again, it could be something as simple as they're not putting something back in the right place every time, and there's a whole audits can detect that. It's not about blaming that person who's doing it incorrectly. It's about seeing if there's any training needs, and those training needs, if one person is doing something wrong, generally there's a few, and it's a training need for a department. And it leads to constant dynamic improvement. When you're in with patients and you see what's happening, and you might see the same thing over and over again and think, why are we doing it that way? Or can we change it? And that's the kind of the biggest thing I probably want you to take away from this is, again, clinical audit sounds really dry but we've changed pathways, and the way we've been able to change pathways is through evidence, through clinical audit. We get extra funding if we can provide this evidence through clinical audit. Generally, your boss will be quite happy if you go ask to change something. They're more likely to say yes if you have backup and you have some clinical audit data behind you. So keep in mind there are things that you might see constantly. Again, you may see them at the moment in repair appointments. The same thing keeps happening, whether it be patients getting from the repair waiting room to your room. Is that a problem? We had, from a repairs point of view, again, it started during COVID. So if we think about some of the auditing and some of the changes that we did then, one of the things that we did was we sent an audiologist round Ninewells Hospital to go actually check the wards to see if anybody needed any hearing aid repairs. He was working as a porter at the time. He was redeployed, so he was sent out from that point of view. Anyway, so he was going round all the wards and he noticed that there were some people who were struggling with a hearing aid, just needed retubed and things like that. And obviously our department was shut, so they couldn't get in. So he started doing that. And actually, we didn't audit it fully at the time, but we did some audit behind it. But that's the kind of things that we changed it because of a reason, because we had to. But actually, is it something we should be doing all the time? Can we see how many patients were seen during that? How effective it was? All these kind of things can be tied in, and actually we can see if that's something we should set up in future. So all these kind of things, if you see something there's a gap and you want to change it, or if you see something that you think is going wrong all the time and you want to change it, clinical audit can give you that information on if it needs changed or not. So NICE have a clear definition of clinical audit. They define it as a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against an explicit criteria. That's kind of the important bit. There has to be a criteria that you're comparing it to. Where indicated, changes are implemented, and then further monitoring is used to confirm if there's an improvement in healthcare delivery. That's kind of what happens. It's a cycle. It's not just a data collection exercise. With so many people who, through the years, it's like, oh, I've done an audit on that. And that's great, you've got loads of information. What are you going to do with that information? Are you seeing if that information is helping you find out if there's a difference that we need to change in patient pathways or patient care, or are we just collecting it for the sake of it? It's really great that we see 50,000 females and 35,000 males every couple of years, but actually, is there a reason behind that? Should we be doing some outreach to see if we can get more males into it? This is a slightly random idea, but actually it's just bringing in those, you're collecting data, you need to do something with the data. It's not just a data collection exercise. So going along with NICE guidelines, what is a clinical audit? A clinical audit involves measuring the current patient care outcomes against the explicit audit criteria. These can be quality improvement projects. At the moment, there will be a lot coming out on quality standards. So it can just be whether we end up with a set standalone quality standards for audiology. We used to have it in Scotland, but it kind of went on the wayside during assessments and things like that. But actually it might come back. Or if we go a little bit more like the English system, and we have UCAS assess, so we follow the ICIPS quality standards. Either way, they all require quite a lot of audit, just to prove that we're doing what we say we were doing, or if we're not, why we're changing what we're doing. It's not a single standalone process. You tend not to just do one audit, and that's your audit's done, job done. You would do an audit again. If there's changes, we change, then you re-audit. So it's always kind of this evolving circle, and that's why they have the audit cycle, which we'll talk about in a little bit. So we know what a clinical audit is, we've got an idea on what we're going to do it on, we have to decide how we're going to collect that evidence. And this is where it becomes a balance, so we can have, it's confidence versus intrusion. So we can have generally the records that we can be really confident in, and the information that we can be really confident in has just a high level of intrusion. Overall, it can be quite intrusive and quite hard to get that data. So the three kind of main ones for evidence techniques for audit are checking the patient's records. So again, if you've got audit base or patient PN, you can go through all the background, all the patient appointments, you can check that someone's filled in the journal, you can see what their audio was, you can do all this. And that gives you historical information, but it doesn't say what's happening at the time. Again, you can do it quite quickly, like you can do like 2 months ago, a month ago, a week ago, but it's never really going to tell you what's happening at that present time. And it's also really open to manipulation. It can go through, you can be checking the records, and it can be you end up doing it with a colleague and you're like, oh, she's not done that, why has she not done that? Oh, actually she probably has, I'll just type that in, we'll just see she's done it. Or someone's typed up after the fact, and that's caused a little bit of a change in what they've actually done on the process. They've missed out a step, they've typed up too quick. Again, there's loads of variations from the checking records point of view, so the confidence in it's quite low. But at the same time, it's got a low intrusion. You don't impact anybody. We can have somebody sitting just going through patient clinical records to see what's happened. The next stage up from that is interviewing. So that's quite good because generally you'll be interviewed staff. So if you're interviewing staff, it demonstrates an involvement of the staff. It's quite intrusive and you'll only get a small sample size. And it's probably a sample size that's maybe quite biased. I don't know bias one way or the other, but it might also be quite biased. But you would hope that from that point of view, staff would be telling you the truth and telling you what's happening. So it's got kind of medium confidence level, but it's also got a medium intrusive level. Staff are generally used to the idea of being interviewed or having someone in with them, so you would hope it wouldn't bother them too much. Witnessing demonstrates a current practice, but it's really invasive and intrusive. So someone's sitting in with you, watching what you're doing with that patient and auditing it that way is quite common, and it gets the highest level of confidence. You can tell what's happening at that present time, but it can be quite intrusive. You guys have had OSCEs by now, so you know the thought of someone sitting over your shoulder and assessing you, so to speak, isn't the most comfortable environment to be in. So it can cause some changes in the way you practice. You would hope actually it would change some people for the better and that they would follow all the rules and not skip anything, but it will tell the most information about what's happening, but it's really quite intrusive. So then based on that evidence we've just talked about gathering, you're looking for the type of audit. So you're looking for there's a vertical audit, a horizontal audit, and a witness audit in this example. So the vertical audit is used to audit all the processes in a pathway. So if you choose something, say a direct referral pathway, you're looking at everything from the pre-appointment, the referral over, the testing, the reporting of the results, and it can go beyond what happens to that patient. Are they discharged? Are they fitted? What's happened when they're fitted? All these kind of things. And the benefit of that is it shows if there's any problems between these pathways, or if there's anything that's standing out alone that might be causing some chaos. For example, the information that the GP is sending you, is the GP sending you enough information that the patient ends up on the right clinic? If not, you can look into the audit cycle, which we'll talk about in a little bit, change the information, give that information back to the GP on how you would like it presented and what kind of information you would like in a referral, and then audit the entire process again and see if it's a smoother process overall. And then if you're looking at the horizontal process, you're choosing one particular process out of this entire vertical process, and you'll track that from one end to the other. So for example, the testing component. So if it's a direct referral appointment, is everything being carried out correctly, or that you would assume and want in that SOP for that process, such as, is everyone doing a endoscopy? Are they doing a questionnaire? Are they doing their PTA? Are they discussing this with the patient? Are they offering the patient this? Whatever you have in that standard operating procedure for that appointment, you're going to want to check and see if it's been done. You can use them kind of as a standalone, so you can just carry out one vertical audit and see what's happening overall, or you can do a kind of combination. You can do the vertical audit and also look at horizontal components. Again, if we talked about earlier on that the referral was going a bit wrong, then you would do a horizontal audit of that referral process, and again you can change it and see what's happening. So the pros and cons of each. So from a vertical point of view, it identifies the gaps between the processes, so between sampling, testing and reporting, if there's any issues in between them. It'll also detect errors in handovers, like if a patient has been referred back and forth, but it only orders that one particular process. So again, it can do the direct referral pathway, but that's a full line of that direct referral pathway. Whereas from that point of view, if you're looking at horizontal, there's a broad brush approach to identifying conformance to wide activities. So you can assess PTA, and that PTA is obviously carried out in a number of different processes, whether it be a tinnitus appointment, a direct referral appointment, an ENT appointment, a vestibular appointment. It's carried out in everything, but it only audits that one step of the process. And again, the examination, the witness, everybody loves a witness from the point of view of its real-time evaluation of competence and what's happening, but it's really time-consuming. We've discussed that it's really intrusive. Nobody really likes someone sitting in on them, watching them. No matter how much you're used to it, it's always a little bit of a strange sensation, and you guys will know that now from your from your OSCEs. So we're going to change shape. So we're going to go into the audit cycle. So the audit cycle can be used after you've carried out a vertical, a horizontal, or a witnessed audit and seen where something needs changed, and how you're going to implement that change as you would carry out the audit cycle. So first you're going to identify the audit topic. Again, we can use the example that we used before. So you've noticed that the referrals from the GPs aren't great. Some patients are ending up on their own clinics. So what you're going to do is you're going to set the standard. You're going to give the GPs information on what information you want in a referral. You can set up a pro forma that they have to fill in. You can just give them guidance on the types of different clinics you have. And then you're going to collect the data. So from making this change, you're going to set a time, and then you're going to collect all the referrals and look at all the referrals. From that point of view, you're going to analyse those referrals. Are they giving you the information that you wanted on the pro forma? Are the patients ending up in the right clinic? And then you're going to implement that change. So if you've seen that it's worked, that's great. This is going to be sent out to all the GPs that you work with, and hopefully that change will become embedded. So again, this is just covering again the main stages again. Select the topic, agree the standards of best practice, collect the data, analyse, feedback the results, and discuss possible changes or any non-conformities that have happened. You're going to implement the changes. What you're going to do is, again, once you've decided that's quite a good thing, you're going to implement the changes. You're going to collect another set of data. You're going to do it again. An audit isn't just, again, a one-off thing. It's a continuous process to see how things are going. Things change, practices change, health boards change, things like COVID comes and everything has to be changed. So you're going to just collect a second set of data, you're going to analyse and re-audit that data, feedback results, and then you're going to discover whether the practice improved. And that's going to be a kind of continuous cycle overall. So why is this important? It provides a framework to improve quality of patient care in a collaborative and systematic way. And when conducted well, it enables the quality of care to be reviewed objectively. And that's quite a key word, objectively. It's not about blame if there is something going wrong. With an approach that's supportive, developmental, and focused on improvement. And the benefits from this, it promotes and enables expected practice, which is good. It makes sure we're all following the same rule book and the same guidance. It provides opportunities for education and training, because it can show those, if errors are showing up or gaps in training are showing up and people are doing the same thing over and over again that's not related to that best practice, it may be a training issue. So you may need to bring forward training to the department, training for that particular skill set, and that's good evidence to say that you need that training, or so-and-so needs that training, or the entire department needs that training. It builds relationships between clinicians, clinical teams, managers and patients. Hopefully these should all be involved in a clinical audit somehow. And obviously it leads to improvements in service delivery and patient outcomes, which is, the patients are what we're here for. So if we can improve their process through all these pathways and their outcomes, it's better for them and it works out better for us overall. So who should be involved in a clinical audit? Basically everybody that's involved in patient care. It's important that clinical audit is supported by those who have the authority to put changes in place. So you're wanting your bosses involved, you're wanting either, from your point of view, your head of service and hopefully their boss to approve clinical audits and encourage clinical audits. In the NHS, there's a policy called Nothing About Me Without Me. This is related to patients, and it means that we have an active duty to involve patients in public where necessary for changing any processes or getting their opinion on things. So a lot of patient forums and patient groups can be really good to provide information on clinical audit, and again questionnaires and things like that for the patients as well. So you go through stages of, is this a clinical audit, is it research, is it service development? They're all kind of based on the same idea. So when is it clinical audit? It's clinical audit if it's based on facts, if it aims to evaluate how close practice is to expected practice. It's specific to one particular patient group, so it's not transferable. So again, if you're doing an audit on PTA being carried out correctly, that's not going to go very well in cardiology. It's not going to help much. It aims to improve services. It's practice based. It never involves a new treatment. It's auditing what we do at the moment, and it may require ethical approval depending on what you're planning on doing. And it changes a little bit if it's research. So research aims to establish what expected practice is. It says to set that standard for the processes. It's generally a one-off study. It's designed so it can be replicated, and results can be generalised to other similar groups. It aims to generate new knowledge or increase the sum of knowledge. It's usually initiated by researchers, not so much by clinicians. It's theory-driven. It's usually testing a new hypothesis. It follows a protocol, and it will require ethical approval. And so when does it become a service evaluation? So a service evaluation is designed and conducted solely to define or judge current care. It identifies the standards that the service achieves, and it measures current service without reference to a standard as such. It's just seeing what you're doing at that time. It usually involves the analysis of existing data, but may also include interviews and questionnaires. There's an audit schedule to this. It's periodic evaluation, it's not a one-off. Robust yet pragmatic is what it should be, and it should be integrated into the management system of a service, and that should also allow for the evaluation of the audit process itself. So you need to audit the audit. So basically, if you're looking at the moment what's coming in audiology, most likely is quality standards. We used to have quality standards and they kind of fell by the wayside a little bit, but these quality standards will be back. And again, for IKIPs and stuff like that, that's one of the variations on quality standards. And part of that includes we have to audit what we're doing. So we will do routine audits on, again, we have a standard operating procedure for how we carry out a direct referral appointment. So what we'll do is we will carry out routine audits where we will look back at X amount of patients within a certain time zone and look through if all the standard operating procedures have been completed for that appointment. So has the audiologist tested the hearing correctly, used the rules of masking when they were supposed to use rules of masking? Have they reported the results correctly? Are they typing the information we need in the journal correctly? Are they reporting back to the referrer correctly? Are they filling out an individual management plan correctly? Have they dealt with the patient? That sounds a bit harsh, dealt with the patient. Have they referred the patient on for a hearing aid? Or have they discharged the patient? Is that what would be our perceived protocol? Have they referred them on for onward referral if that's required? That would all be checked. And what would happen is that it's basically a score sheet. We have a score sheet, we tick everything off. Beautiful, you see X amount. If you see that all the audiologists that you have assessed have not carried out the questionnaire, then you need to go back and find out why that questionnaire has not been filled in. Is it because they don't like it as an outcome measure? Is it too long? Do they think it's a bit pointless? There could be a whole array of reasons why that questionnaire has not been filled out, but you may have to look in and change that. So that's what the audit will pick up. That'll be one quarter's audit, and again, probably in another 3 months there'll be another X amount of patients picked in the same thing seen to see if the same patterns are coming over and over again, whether these patterns are audiologist specific or whether departmental specific. Is nobody carrying out an outcome measure? Is one person not masking correctly every time? It just means that we can constantly see that we're doing what we say we're doing, and that's when it becomes a service evaluation. So from a confidentiality and ethics point of view, a clinical audit by definition does not involve anything being done to the patients or changing anything for the patients other than normal clinical management. So it may not require ethical approval, but it should be conducted within an ethical framework. You have to look out for data protection ideas. So you have to make sure that no patient details are being passed on, all these kind of things. Caldecott principles come into play in some places. So we have, if we're med students are looking at our data, they have to have Caldecott guardianship, which means they're allowed to go in and look at our data and looking into our patient management system. And it's only for a justifiable purpose. They'll be allowed to go in and audit for one particular thing. They don't get to go into all the patient notes, because we have a duty of confidentiality and a duty to protect that patient information. The same idea is if we have a referral for a hearing aid or a hearing test, we get access to the clinical portal, all that previous patient's referrals. We can't just go in and have a nosy at all the referrals, so it's the same as they can't do it either. We can only look at stuff that's specific for us, so an audiology referral, an ENT, sometimes health psychology information. because we need to protect patient and staff confidentiality, because if you're auditing a process, it may be that the staff are the ones that are getting involved. Again, that same idea of Outlook questionnaires aren't being filled in. You don't want to again blame a particular member of staff for that every time. So I don't know if you've realised already, but I love a TED Talk and I love a YouTube video. So this is a TED Talk by Ben Goldacre. It's talking about battling bad science. It's a few years old now. It's not that long, but it's really good just to have a quick watch of it. It gives information on journals presenting their information, newspapers picking it up, and all these kind of headline stories of eating bacon causes cancer, this kind of thing. So it's worth searching. I don't know if you'll get the link from this video, but that is a link there if you're typing it out, or it's just Ben Goldacre battling bad science in YouTube or in Google, and it'll pop up. And this is just because I feel that we should mention clinical governance, because we're talking about all these kind of clinical processes and making sure we have high standards of care and making sure we're adhering to those high standards of care. So the fundamental overriding principles behind that are linked with clinical governance. So again, making sure we have the right education and training, making sure there's risk management, making sure there's clinical audit involved, clinical effectiveness, research and development, and openness are all kind of the key standards of clinical governance. So it's just to say that overall. So then if we look at things like sampling, I should point out from this and the future slides on this presentation, not a statistician, and you will get this from your stats lecture. It's just to kind of cover and base some of the things that we've been talking about and tie it in a little bit more. So if we're thinking about sampling, one of the first things you want to think about is sample size, and that's obviously really different depending on what you're looking at. So say you're wanting the same information from a group of hearing aid users as you're wanting from a group of implant users. The sample sizes are going to be very different for both of them, so you need to look into that. It's probably quite easy to get a sample of 300 hearing aid users without too much difficulty. You just have to look over a certain period of time, whereas getting a sample of 300 implant users will be quite difficult when there are only 140 implant users that have been implanted since they started doing implants in the department, that kind of thing. And then if you look at the types of sampling, so you can do random sampling, so systematic sampling, selected according to an individual, between individuals. So again, we're going to select every third patient that so and so sees, or every patient who arrives at 10 o'clock, 12 o'clock, 3 o'clock on this day. It can be stratified, so divided into groups, geographical areas, etc. And T-side, we can look at samples from, which probably ties in more to the cluster sampling more from patients from Fife, patients from Perth, patients from Dundee, those kind of things. Again, clusters or schools, or if you're looking at paediatric, you can do cluster samplings on patients who go to particular schools, that kind of thing. Purpose of sampling, so you choose who you're sampling on purpose. You're going to choose anybody who attended that day or anybody who attended that clinic, that kind of thing. Convenience sampling is just things like patient questionnaires, so you just hand them out and see who responds, kind of overall. It's doesn't require much effort to decide on who you're choosing for a patient questionnaire. And then when we're wanting to think about reporting this information, some basic descriptive statistics can be used. So you've got your averages. So mean can only be used if it's a normal data distribution. There has to be a decent amount in the data set, and you can use the standard deviation to see the spread around the mean. The mode is the most frequently occurring value in the data set, and the median is the middle value in the data set when all the numbers are arranged in order. So if the data is skewed, which is most of the time in clinical audits, it could be quite good to use the median. And you can use a range as well, so the highest values and the lowest values. Patients waited either 6 days for their appointment or 132 days for the appointment. In our clinics, it can be as broad as that. So it's quite good to see the range of the appointment, do a run chart from that point of view, and it can provide us a little bit more information, because obviously you would hope that those two endpoints are really skewed data points. You can also use the quartiles and the interquartile range. and it just shows you the information on distribution of values around the median. And this slide seems to just be a nice table format of the previous information that I've just given you, just to make it a little bit easier to read. So you've done your audit, you've pulled together all your data, you've analysed your data, it's time to present your findings. I keep thinking of this in the form of, as a clinician, I've done some basic clinical audits, and how we would usually present them is we would present them as a poster. So I keep thinking of how to present your data so that it's quite striking and it's obvious. So if you're presenting at a conference where there's hundreds of posters, someone will come over and be able to see yours and understand yours and be drawn to yours. Obviously, we can also present the data in small talks, again at conferences and things like that, just to pass over the information, and you're wanting hopefully those presentation slides to be colourful. So I keep thinking of this as a kind of a visual medium. If we are presenting in journals, obviously it's not quite as visual, it's a bit more black and white almost, it's a bit more wordy and black and white. So it depends how you are presenting your data overall. But if you think about tables are good for frequencies and percentages, you only kind of want to use percentages in the cases where you've got a valid data set. You don't want a teeny tiny sample size. So you've got a sample size of 3 and you can say 60% didn't show up. Doesn't sound great. If you've got a sample size of 300 and 2 didn't show up, sounds a lot better. You can group continuous data into groups and give a frequency percentage, so you can give some percentage information. Graph wise, you can do a bar chart, histogram, line graph. So here's a table. So again, this is from vestibular clinics, I think. So again, you've got 30 clinics. Out of those 30 clinics, you had 107 patients, 4 DNA'd. The percentage of that is 3.74, 103 attended, 5 were referred to ENT, so 4.8%. The longest wait was 110 days and the shortest wait was 11. So your average wait is about 37 days. So you can present it like that. It says a little bit dull. I'm a fan of an infograph. All my things seem to have infographics. Even my pathways have infographics. But again, it's quite nice to see that only 5% of patients were referred to ENT out of that patients that we've seen. So it's quite nice to see it that way. And this was actually used to present a test of change. So what this was that we were going to take on ENT's patients direct access for vestibular. So this gave really good evidence on that one stat alone, that less than 5% of them were referred on to ENT. Audiology dealt with 95% of them. And previously, all those patients would have been going to ENT. So it was a really good indication that actually we should maybe change this patient pathway. And again, from tables to charts, this could be presented in many different ways, but the pie chart works quite well for it. So conditions diagnosed in this clinic, it just gives a nice clear indication straight away that BPPV was the most commonly diagnosed condition in that clinic, and that other was the least common. So other vestibular, in this case, it would have been written up, but Meniere's and vestibular migraine and things like that. So it just, again, draws your attention quite quickly to it to see what's happening. So when you're reporting on a clinical audit or any research, it'll all pretty much have the same headings that you're going to report to. You'll have your title, you'll have a background, you'll have your aims and your objectives, the methodology, the results and the conclusion, an action plan of what you're going to change, and obviously the references and appendices that you're going to have in. And then the final part is to disseminate your findings. And this is why I don't think clinical audits are dull, because I think when you've pulled together all this information and sharing that information, especially if it's been a change that's been beneficial for everybody, it's really nice to share it with the wider community of audiologists generally, or scientists, or healthcare scientists. So it's good to get that information out there. This can be the form of reports. Again, it can be in presentations. It can be standing up on a stage presenting, or it can be the poster presentations like I was just talking about. The BAA conference every year, again, presents posters. There's talks of everybody who's doing clinical audits on what their current pathways are, if they're changing pathways, how they are carrying out their clinical appointments. Everything's down there, so it's really good to share that information. National events, so such as the NES healthcare science events, or local events, usually your health board's got some sort of events. It's good to get that information out there and show that we are working to best practice. We are trying to change practice and innovate healthcare and things like that. And I think as audiologists, we don't always do this as much. Medics do it a lot. Obviously, the med students have to do a lot of part of their curriculum is basically to write up reports and do some clinical audits, and I think we should be doing this a lot more and giving our findings out over these forums. And that's me. Thanks for listening. So thanks for listening to my whistle stop tour of auditing.